behalf of the Integrated Health and Wellbeing Council, I welcome all of you to this session on multiple sclerosis, which is an initiative by the IHW Council and supported by Roche. I'm your host, Dr. Behjat, and today we'll be discussing about navigating multiple sclerosis, unveiling the signs, managing the symptoms, and understanding the risk factors. And to discuss about this often neglected disease, I have a very special guest with me. I have with me Dr. S. Mohandas, who's the head of Department of Neurology, Krishna Institute of Medical Sciences, Secunderabad. Sir, thanks for joining us and taking out time from your busy schedule.
Thank you for asking me to speak about MS, which has been my sort of most interesting area of involvement over the last 5 decades.
Okay. Yeah. So thanks for coming here, sir. Without further delay, I'll just start the session. So from a clinical perspective, sir, how would you define multiple sclerosis, and how does it impact the communication between the brain and body, specifically focusing on the autoimmune response triggers?
The MS has been the main problem is it's a chronic disease. It stays with you for a long time. It remains without giving notice within the body for a long time. Even when it makes its first appearance, already a lot of damage might have accrued. So the first episode doesn't mean the disease is starting then. It is started much before, but it is showing up now. This is one of the major single factors in MS, which has kept the diagnosis of MS a pretty difficult one to make over the years. So of course, it is always considered a disease of the West, based possibly on, I think it's a very important thing to consider that the MS is more common definitely in the West, especially in the colder areas, especially Scandinavian countries, US, Australia, all these places, they have much more. Europe, of course. But it's been almost considered non-existent in Asia. Now, the major issue with multiple sclerosis is it predominantly affects the myelin, which is actually a sheath around the nerves. Like, wire, a nerve is just like an electrical wire with an insulation and a core, which is copper wire, which we just generally see. So in multiple sclerosis, major brunt falls on the white matter, which is called the myelin, that is the insulation. So in the process, the actual neuronal damage may be a little later. The nerve cell or nerve fiber may survive longer and the myelin gets affected, and myelin has capacity to reform to a certain extent. Whereas if the nerve cell or nerve fiber is damaged, the chances are much less. So what happens is when this particular thing happens, where any place in the brain where this happens, which is eloquent, that means if it's in the optic nerve, which is the nerve to the eye, you will lose vision for temporarily or on a longer basis, but it tends to usually more often than recover because the sheath reforms. But again, this may happen somewhere else, and it may produce problems of speech, problems of language, problems of understanding, or weakness of limbs. Any one of these can happen. And so MS can, depending upon which part of the nervous system, either the brain or the spinal cord, because it affects the central nervous system. It doesn't affect the peripheral nervous system, and by and large.
Right, sir. So you have given us a very lucid overview of the disease itself, where it is found, what is the regional disparity when we talk about the disease. Coming to the diagnosis part, because you said that diagnosis is a difficult part in MS. So what are the ways, how do, as a clinical person coming from that background, how is it clinically diagnosed?
See, the situation is, MS has been known over the number of years, okay? In the sense more than maybe 200 years, 300 years, maybe more by autopsy. The name was given because of the pathological change where there's a plaque which is sclerosed. That's why it's called, and it's number of places, so it's called multiple sclerosis. Earlier, it used to be called disseminated sclerosis, but the word changed to multiple sclerosis because not present everywhere, but at different sites. So at multiple sites, there is plaque formation which becomes very hard. And so that's why it's called multiple sclerosis. And the diagnosis was very difficult. It was not very clear for a long time as to how one should address this disease. So it was predominantly actually in 1965, they had a committee to say must have criteria, at least clinical criteria, which say that these are the likely chances that this is multiple sclerosis, where it's usually age group is about younger age group, more often in females, as any other autoimmune disorder happens, where the immune system is affected within our body. And so this affects ladies more than men. And that's why this diagnosis possibly occurs in younger people, maybe with affecting more of the white matter. There are some clinical signs which tell you the white matter is involved, and some which says the gray matter is involved. There are differences. So if you find predominantly white matter involvement, occurrence of more than one occasion, and occurring in this age group, one would seriously. And the person who really brought the clinical criteria, whom we think is been father of MS in some ways, is Dr. Schumacher from Burlington, Vermont in USA. And he was almost a word to reckon with, and he was the one who laid down the clinical criteria. But clinical criteria still led to so many problems in making a diagnosis because a lot of other things were thought to be multiple sclerosis did not turn out multiple sclerosis. But so subsequently, there have been efforts to change in diagnosis by looking at something like we call as CSF examination, which gives you some clues towards diagnosis. But it was MRI, which came up in 80s, which made a total change in the outlook as far as MS is concerned, as far as diagnosis is concerned. It went through, it started from, say, late part of 1980s, the diagnostic criteria got built up, then each one changed. By 2017, I think, even the first episode, we could possibly identify MS without necessarily having a doubt about the diagnosis based on the MRI and the clinical features. So I think it took some time, but now we have even the first episode in MS can be identified. As I said before, MS could not be diagnosed on a first episode. Now we call it as a clinically isolated syndrome because it affects at that particular point of time. And then when you do an MRI, it sort of corroborates the typical features of MS in the MRI. And then you do a CSF and find some abnormality. You're almost there, that you have got the diagnosis in hand. So previously it was by exclusion. Now you can make a diagnosis by inclusion. So I think that is the most important thing which changed over the years as far as diagnosis is concerned.
Right, sir. That was a very insightful answer on how, how it is diagnosed and how the benchmarks have changed over the years. Coming to signs and symptoms of MS, which differ among patients themselves also. One patient might have some signs, somebody might experience something else. So what factors contribute to this variation? If you could just highlight those.
Possibly it's because, as I said, it is an autoimmune disease. The most important thing to understand the number of targets within the immune system which can be affected in MS. In a given individual, it might be a little different target from the other. And so it might involve more often in one individual effect, say the eye, optic nerve, for instance. In some, it may affect the brainstem. Especially another thing which we see is depending upon where it starts, because I think of all the involvements, I think the optic nerve involvement is relatively more benign. Whereas if you have involvement of the spinal cord or the brainstem, your likelihood of developing disability faster is evident. See, earlier, without treatment, a patient with MS would possibly become wheelchair bound in 12 years. Now, you can possibly live a full life based on early diagnosis and possibly instituting treatment, which was, again, treatment was not available for a long time. We'll come to that possibly in your next question or two.
We will come to the treatment part, sir, after one more question, which is about how, because you talked about disability and how a person could become wheelchair bound because of MS. So, what are, in your experience, how does MS impact, individuals' daily lives, and how some examples from your, patients, and how it differs from.
Yeah, as I said, for example, if suppose your first episode of MS happens to involve the eye, and if you suddenly find you have lost your vision in one eye, it's a very scary, absolutely scary thing. As it happens, fortunately in MS, it usually affects one eye. It doesn't affect both. And more often than not, first episodes tend to recover very well. So I think first there's a reassurance, and usually you treat a little with steroids at that point of time, and you get a very good response. But those people who, as I said, if they involve the brainstem more often, that produces quite a significant problem of sometimes double vision, swallowing difficulty, walking which you say unsteadiness of gait, so makes you terribly wobbly. And third, another area, of course, is involvement of the spinal cord, where your lower limbs or upper limbs are also very weak. They're not able to move. It might involve your bladder or bowel function. They may not be able to control them. These things make a very, very difficult life to lead. And they are not only difficult from point of individual, they're embarrassing. They need to be taken care of. You need enormous amount of caregiving. All these factors possibly add up to individuals' life and make them very difficult to handle. In addition, of course, one other factor in MS is possibly the most important thing which one should understand is a feeling of severe fatigue. More than what actually looks, the person is absolutely exhausted, a feeling of not feeling good, not feeling comfortable at all the time exhausted. Even a small task becomes very, very difficult to perform. This fatigue overwhelms many other findings. And also you can't see the individual having any deficit as such. So people might think that, it's more of not really reacting or feeling depressed or something like that, rather than actually the disease process itself.
Right, sir. So we will come to, like you talked about, caregiving and how it's a whole journey, So we'll come to that part later. Talking about the current treatments available for MS. Please enlighten us on that.
I think, again, as I said, most of the effort towards MS was made in the years like 90s and early 2000, and maybe even possibly even today, but less so. The diagnosis was the major reason of work that time. Now, I think diagnosis has become relatively simpler, but treatment modalities were only available for the first time in about, say, mid-90s. And they were available in this country only in early 2000, 2001, 2003, maybe. First one I treated actually was 2004. So it's about 20 years of treatment modalities which we have done. And they have gone through different mechanisms. Now, as it happened, as I said earlier, since there were different targets in the immune system, different immune modulators or immune suppressants in various modalities of treatment, injections, then subsequently oral therapies, then more injections, and more potent medications all came for this thing, and possibly even to the extent that most of the medications are now considered predominantly keep the MS at bay. You see that there's more attacks don't occur, and that allows minimum progression or no progression at all. But in spite of using all this, there can be progression in the absence of clear attacks as such. So what other modalities also of treatment have come, where you can possibly get rid of any treatment at all for MS and maybe offer a cure in inverted commas by possibly doing two treatments of very potent nature. One is a hematopoietic stem cell transplant. And second one is a drug called enlightening, which was originally a cancer drug produced in Cambridge, which was called Campat because it was produced in the laboratory. And but at that time in cancer, it was used as a very high dose, produced a lot of side effects. So it took some time. It's something like 1960. Now it is available in 2000 plus, 2000, maybe 2011, somewhere around there, that the drug really took off. So I think there are a number of drugs now today available. As I said, first drugs which came in were called interferons. They were actually original drug which was used called alpha interferon, which actually enhanced the disease. Then they found the beta interferon is definitely reduces the risk of relapses, reduces progression, but in a moderate fashion, maybe about reduces relapses by about 30-35%. So then a new drug came. I think it was somewhere in 2009, 2007. And this came with a big bang. Because it's a very potent drug, it had a specific action at one particular site in the immune system called alpha integrin. But this drug was very powerful. It was to be given once a month. And the first time you could see that the person felt good, the fatigue disappeared, and no relapses came down by significant 55 to 60%. And the progression of this disease was altered to a degree. And when you did clinical examination or MRI, you found no evidence of disease activity. This drug is called netlizumab. It's also called Tysabri in trade name wise. And this gave fantastic relief to many people. As I said, I happened to visit at one point of time a place called St. Gallen's in Switzerland. And they had almost like an assembly line. People would just come, just hook up, finish off the infusion, and then just go back to work. And they would feel good. I mean, that's that sort of drug it was. And it was approved on a fast track by FDA. And expensive. But anyway, before it was introduced here, something else came up in the sense that it did, because you alter the immune system, somewhere else you are prone to get into some problem or the other. That means you might get infection of some very rare infection. There's something called a JC virus infection called progressive multifocal leukoencephalopathy, which tends to affect, once it affects, it's a little significant morbidity and very high mortality. And so you have to be very cautious of using this drug now, because when actually at one point it was withdrawn and reintroduced. And so now when we use it for a period of 2 years, very comfortably, even in those people who are otherwise JCV virus positive, even those 2 years is okay. If they are negative, you can continue on longer term, but the people who are positive too, because they feel so good on the drug, but monitor closely for the development of this side effect. Still, it's one of the very popular drugs used. And so this is where one of the drugs which I was talking about. Now, subsequently to that, there were a few oral therapies which came in. And this, because it's a rare situation that you started, of course, with injections first, and now you're going to oral drugs. There are few drugs which came up. The most popular of them seems to be a drug called dimethyl fumarate, possibly one of the commonest drugs used in MS today. It's 2 tablets a day. But as I said, these are tablets which you take like anything like hypertension or diabetes. You take them for life. Keep a little monitoring on your what you call immune system, possibly doing a little, looking at liver enzymes, looking at your hemograms. These are necessary for any one of these drugs. Some of these also, again, have very major impact on pregnancy, because as I said, a lot of women are in the reproductive age group. Most of them are working women now, and a lot of them, and surprisingly, as we see, that MS seems to occur more in the better off economic class rather than the poorer economic class. So possibly, see, in the sense, to a certain extent, this can be thought of in the as that in United States or the West, the immune systems are keyed a little differently. In the sense, they are exposed to different things than we are. We are exposed to very common tuberculosis, malaria, dengue, these sort of things. Those people are exposed to more viral fevers rather than, and they're protected much better. And so the immune system possibly get triggered by different. This is one of the reasons maybe it was more common in the West. Now we are seeing it more common here. Maybe not all this high as in the West, but because partly we make a better diagnosis now, which reach a diagnosis much earlier. And second thing is these are, as I said, affects the better socially economical people. They have better, different immune systems from what we used to have. We used to, as a children, we used to go bare feet. We never had shoes on our feet. I'm talking about 60, 65 years ago. So what I'm trying to say is it's not anymore what you see with children anymore. They don't get into such sort of situations. So their immunities are different. Their vaccination schedules are different. So all these things have had an impact. And so treatment modalities will depend on how severe is the disease. When you identify, the most important treatment modality to be used is possibly more than what, but when. The earlier you can identify, and if you pick it up in the first instance, as I told you earlier, if we can start treatment early, maybe then even a simpler drug will do very well. You may not need very potent drug. Then if required, some people are a little more aggressive in their disease. Those people require more potent medicines. And those who have a milder, they have been on interferons with me for about 20 years. They have now come off, some of them have come off medication after age of 60. Again, there's no clear recommendation there, but that's where things go. But those who are, some of them requiring early aggressive therapy because the active disease. So I think these are all the factors which we take into consideration when we institute which drug to use, when to use. Third area. Okay, I think I've covered most of that, but I think maybe next question or two of yours, I will be able to give you better.
Yeah. So, sir, if we talk about, since the treatment modalities you have covered in a very, very, nice manner, coming to the counseling aspect, because you talked about how you touched upon how caregivers play a very important role. So counseling of patient plus the caregiver and the family. So is that a part of the holistic, that multidisciplinary approach is there? How is that managed?
No, you see, it's inevitable because it's a number of times, as it happens, the present MS patient in our setting is also the breadwinner. And so the household revolves around. And she's also the one who gives the children. Pregnancy, the disease has an effect on the pregnancy, and the drugs have an effect on the pregnancy. All these factors have to be taken into consideration when you counsel that when they plan to go, certain drugs cannot be used for pregnancy. There's a drug called teriflunomide, which we tend to not use in this. But otherwise, it's a very good drug to use. It's a one-day dose drug, but it is not for people who are planning pregnancy. So we have to counsel that way. Second thing is the fatigue part of it. A lot of people just looking at the patient looks good, but she's complaining of fatigue, not able to really. Now, there are some drugs which help in that fatigue. The counseling and part of that is very important. Counseling about pregnancy is very important. And it's very important to tell them that we treat them as early as possible. And it's not treatment which we give up early because we do it in a long-term case. It's something I always tell my patient or caregivers is, it's just like having diabetes or hypertension. You're going to be on treatment for life. This is also most of the time for life. But sometimes at least there's hope that we may give up at some point of time, unlike the other two. So you need to be on that part of it. And encourage activity without necessarily pushing the person. But the more active the person is, better it is. So allow for physical activity, then possibly mental activity. Both will help in keeping the whole environment around very good.
Right, sir. So you have talked about how having an active lifestyle, doing physical activity helps. Are there some other interventions or strategies that you would suggest to help individuals maintain a high quality of life?
Two more things. I think there is one is that temperature has a very deleterious effect on the symptoms of multiple sclerosis. There's a very peculiar phenomenon in the sense that if suppose you had loss of vision long time ago and it recovered fully, but you find sometimes that when they go into a little hot atmosphere, they find that the vision drops temporarily. This is named after a person who called Uthoff's phenomenon. It can happen with the legs. The weakness might develop there. The vision might come down. These symptoms may reappear for a short while, very brief, transient. And so you should possibly avoid very hot situations in our country, all the more that's very much this thing. But although today, most of us seem to be more AC bound, either at home or at work, because things have remarkably changed since then. So summer comes and goes without people realizing summer is there. So I think that's one care one needs to do. Second thing is there are some symptomatic therapies which also need to be, for example, if you have involvement of your bladder, your control over this, there are some drugs, there are some practices, some minimal, small procedures which help in controlling these. Similarly, you have significant fatigue, there's some drugs to improve that. Then people who have recovered but still find walking is sometimes, there are some medications which help that also. I mean, these are symptomatic drugs, but I think in the process of only diagnosing and treating specific areas, we sometimes neglect very important areas which count for the patient and the caregiver. And so those have to be kept in mind when you counsel them.
Sir. So if you feel that since the conversation was so interesting, I was deeply, involved in listening to you, but I think time has its own, a way of reminding us that it's about time. But before we leave you, I would just want to ask you one key message for people, who are who have MS or any other thing that you think is important, should be discussed, and we have left in the whole course of conversation. Any parting note, major takeaway from
one most important thing which I have not talked about is the social area. I think we have societies like Multiple Sclerosis Society of India. They're doing a fantastic job. I think it started initially very well in Mumbai, but it has spread to almost all cities, major cities. It requires appreciation because they go and help these people even at home. They conduct meetings which call people who have some knowledge of MS and then interact with people who are interested in helping these patients. And they even help people how to go about their, overcome their disabilities to a certain extent, how physiotherapy is important, how the ability to keep yourself going is important. I think these societies do a fantastic job. MSSI is remarkably doing a great job in most of this. Hyderabad also does a very active program. So I think I must appreciate those people really who do this. And not the least is pharma companies which have produced these medicines at a very high cost. They sell at a very high level in US, but they have made special allowances for patients with MS in this country. And there are few drugs which have come, say, from Europe. There's a drug called rituximab, which is showing good, promising results and is much less expensive because economics is a very important area for our country. it's not covered most of the time, is not covered by insurance. And so these are some of the major factors when I treat my patient with MS. I think of all these. So because these are very, very pertinent to the patient and the entire household. So I think those are my possibly few last words about MS.
Thanks, sir. It indeed was an enlightening discussion, and I'm sure our audience today will take a lot of relevant awareness on MS, which will help their friends, families to, to use that information for the benefit of their health. Thanks for being with us. Thank you very much for taking out time from your busy schedule and joining us for this session.
Thank you very much. Anyway, Saturdays I'm off.
Thanks. We'll keep that in mind. Thank you. So that is all for today. Thanks for watching us, all of you. And please keep on following our social media for more updated information on health and well-being. Thank you.